Professor Rachel Neale. Rachel is actually a group leader at QIMR Berghofer. Rachel is the principal investigator on the D Health trial, one of the largest trials for vitamin D globally. It's published more than 260 papers. And Rachel is going to present some her recent work on the understanding about the role of vitamin D in human health.
Thank you for the opportunity to speak to you today about the D Health trial. We believe that D Health is Australia's largest and longest trial involving delivering a drug, in this case, vitamin D to somebody. So this was a trial of 21,315 people that ran for 5 years. And I'm going to try and tell you all about the trial in 10 minutes. So I'm going to leave out more than I'm going to tell you and probably leave you with many questions. So just to start with, why did we think we needed to do a trial of vitamin D? So when we started this trial, there was a huge amount of hype. In observational studies, vitamin D had been linked to over 100 different health outcomes. There was a huge amount of media around it, but whether or not it was those associations were causal, we didn't know. And at the same time, we were seeing this explosion in vitamin D testing in Australia. Between 2000 and 2010, there was about a 100-fold increase in the number of vitamin D tests per capita that were being conducted largely by general practitioners, despite the fact that we didn't know the importance of vitamin D, and vitamin D measurement, the measurement of the molecule that we have, was incredibly poor. And I just thought I'd show you that actually subsequent to the trial, what happened was in the end of 2014, Medicare decided to crack down on what they considered to be overuse of vitamin D testing, and they changed the item numbers and changed the rules for who could be tested. And then you can see that there was this big drop pretty quickly, but it's been on its way back up again, and we're still seeing it going up further. So there's no good clinical reason for that. And almost certainly that vitamin D testing has been driven by hype. At the time we began the trial, there was also a lot of discussion about should we be doing population-wide supplementation, potentially through food fortification. So there were a lot of questions that we needed to answer, which is why we launched into this trial. So the trial really aimed to ask the question, does population-wide supplementation of older Australian adults improve health outcomes? Because we knew we were launching into something that hadn't really been done before, a big community-based trial where we never saw a participant face-to-face, we decided we should pilot this. So from 2010 to 2012, we did an AAHMS-funded pilot trial, a big pilot, 644 people, which for many trials is actually quite a big sample size. On the basis of the success of the pilot, we then got funding to begin what we call Big D Health. We recruited in 2014, in the early part of 2015, as I said, over 21,000 people. We intervened on them for 5 years, and in the subsequent few years, we've been doing data linkage and analysis. So just in terms of the trial design, a randomised, double-blind, placebo-controlled trial. Participants were Australian adults aged 60 years and over, who didn't have any contraindications for vitamin D supplementation and who were not taking more than 500 international units of vitamin D per day. We asked them to take 60,000 international units of vitamin D per month or a matching placebo. We got them all to take the tablet on the first of the month, and on the day before, they would get multiple reminders from us not to forget to take their tablets. And I just wanted to give you some justification for using that monthly dosing. The molecule that we measure is serum 25-hydroxy-D. And whether or not you give that sort of same equivalent dose daily, weekly, or monthly, you get a very similar change in 25-hydroxy-D. And by using a monthly dose, we get much higher compliance than you would otherwise get. The trial outcomes, the primary outcome was all-cause mortality. Secondary was total cancer incidence and colorectal cancer incidence, which we haven't yet analysed. We're in the process of doing that at the moment. There are delays in cancer registration. And then many, many other outcomes, including some sort of intermediates that are potentially of interest, like telomere length and gut microbiome. I'm only going to tell you about a couple of those today. In terms of measuring outcomes, we asked people to complete surveys every year, and we got 98% of those back. And that helped us measure some of our softer endpoints like pain and mood and things like that. We did linkage to the Medicare, MBS and PBS databases. And we also linked through the state data linkage units to hospital admitted patient data, cancer registry data, and mortality data. And this linkage, as you heard before, is incredibly important because it means we get complete data and we're not missing any data which can cause bias in these types of studies. We're proud of our approach to data analysis. As is standard in trials, we used an intention to treat principle, and we mostly used a type of modelling that enabled us to look at estimates at different time points. But what's really important is that for a trial of this size with many, many different outcomes, we run the risk of kind of going hunting for things. So for each of our outcomes, we created an incredibly detailed statistical analysis plan, which included writing all of the statistical code to produce all the tables and figures, which was written using dummy data. So basically, we removed the randomization code. So we didn't know whether or not people were in the vitamin D or placebo groups. We just randomly assigned them to two groups so that we could write all the code. We showed all the plan tables and figures to the co-authors for their review and approval. And only once we nailed all that down did we apply the code to the real data. And then if we found something really interesting at that point in time, we went ahead and did some exploratory analyses, but we claimed them as exploratory. And I would just like to say that a lot of our analysis has been overseen by Mary Waterhouse, who's an extraordinary statistician. We've published a lot from this trial over the last few years. Another one's just coming out now. I'm going to tell you about a couple of these outcomes now. So we sent invitations to people randomly selected from the electoral roll. 421,000 invitations were sent in order for us to recruit our 21,000 people. So a big loss there. I'm not going to show you, but in fact, our population was reasonably representative of the Australian population, despite the relatively low response rate. The compliance in this population was excellent. We took blood samples from a random sample of people each year. So in total, we had about 4,500 blood samples. And the difference between the 25-hydroxy-D concentrations of the two groups was maintained over time. There's about a 35 nanomole per litre difference. We also asked people about their use of their supplemental placebo over time. And as you can see, that over 80% of people were what we classified as compliant, which is taking 80% or more of their study tablets. And a really extraordinary testament to my team's performance that at the end of 5 years, we still had 80% of people taking tablets, which is an extraordinary outcome. So getting into some outcomes now. Our primary outcome, all-cause mortality, we had 1,100 deaths in the population, and we did not see any benefit of vitamin D with a hazard ratio of 1.04, a relatively wide confidence interval there, suggestive of benefit or the potential for harm. We looked at major cardiovascular events, which were classified as having a myocardial infarction, a stroke, death from cardiovascular disease, or a coronary revascularization, and there were 1,336 events. And you can see that we did see some benefit of vitamin D supplementation, albeit borderline significant. Assuming that is a real association there, real effect, you would need to actually treat 172 people to get one improved outcome. But what we did see is that in people who were already taking statins or cardiovascular medications at baseline, we saw a quite large and statistically significant effect of vitamin D supplementation. So these are probably people who are at increased risk, who are more likely to benefit more. In terms of fracture, we know that vitamin D is important for fracture, but there's a huge amount of controversy over whether or not supplementing people who are not frankly deficient is of benefit. We found some evidence of benefit, again, not statistically significant, but we did see a big shift over the 5 years of the trial. And at 5 years, we found a 17% reduction in the risk of fracture in people who were supplemented with vitamin D. And it's not surprising that we might see an effect emerge after a longer period of intervention. Vitamin D might play a very important role in the immune system, including for infectious disease. And we looked at this in a number of different ways. So this is looking at the risk of acute respiratory infection. And we found, top line here, we found no benefit for whether or not people experienced a respiratory infection, either using survey data or in a sub-study where we asked people to complete cold and flu diaries. But what we did see, and this is consistent with vitamin D potentially down-regulating an overreaction of the immune system, which is often what causes more severe symptoms. So we saw a reduced number of days with symptoms, a reduced number of days with a severe symptom score, and a reduced need for symptom relief for these respiratory infections, and reduced antibiotic use, albeit with a very wide confidence interval. We also looked at other measures of infectious disease. So we looked at antibiotic use for any reason. We just used PBS data to look at whether or not people had been prescribed an antibiotic. And what we did see here was a very slight, non-significant reduction in prescription episodes. But in people who were predicted to have a vitamin D deficiency at baseline, we saw a reduced number of prescription episodes. Overall, we saw a reduced number of repeat prescription episodes. This is where people needed to have more than one prescription in a single episode. And again, a stronger effect in people who were deficient at baseline. We looked at hospitalisation for infection, wide confidence intervals, but potentially some benefit. But importantly, in a pre-specified analysis where we classified extended hospitalisation, so people had to stay in hospital for longer, we saw a reduced incidence in people who were taking vitamin D. So this all adds up to there being a potentially important effect of vitamin D on infectious disease outcomes. So I've only given you a little bit of information from the trial, as you saw many other outcomes. But what are the implications for policy and practice? Well, we think we need some economic modelling to consider the potential benefits of population-wide supplementation in Australia, because although we saw small effects at a population level, these could actually translate to benefit. Importantly, there does seem to be evidence of benefit beyond musculoskeletal health. And so policy at the moment should focus on making sure that we don't have people who are vitamin D deficient. And we know that that is more on the equity issue. We know that vitamin D deficiency is more common in people who are particularly migrants who have dark skin. But at an individual level, people often say to me, I'm not vitamin D deficient, so should I take vitamin D? To which my answer is, look, I'm not really sure. At an individual level, yes, it might offer you some benefit, but it does come at a cost. And for things like cardiovascular disease, it's probably not going to be better for you than a healthy diet. It's not going to be a magic bullet. So if it's a choice of buying apples versus buying vitamin D supplement, I'd probably recommend the apple. So it's really going to come down to a personal decision at the moment rather than a population-wide recommendation. But with increased modelling, we might move to some sort of population-wide supplementation or food fortification. A trial like this, 10 years worth of intervention over the pilot, interventional follow-up over the pilot, and the large study doesn't happen on its own. It was all funded by the AAHMS and a lot of people who've done an extraordinary amount of work. Thank you very much.
Rachel, can I ask you, are you any planning to follow up for autoimmune diseases, particularly MS?
So the question was about autoimmune diseases. It's a very good question. MS, we can't really follow up on because it occurs younger. So our people were all over 60 at the time we recruited them. And so most MS has occurred prior to that. And we don't really have the ability to look at deterioration in MS. But what we have looked at is hypothyroidism, which often occurs later in life. That publication is about to come out. And it does suggest some potential benefit for women, but not for men. And hypothyroidism is more common in women. So,
Hi. I have a question at the beginning. You said when you showed the chart, right? 1 day, 7 days, and then 28 days. So if I take a high doses once, after 28 days, it's the same if I take every day a low dose.
yeah.
So where is it stored? Is it mainly stored then in the bone and the marrow and so on? Where does it go? And I'm surprised. I saw that the half-life of vitamin D3 is much, much smaller time scale. So how do you explain that? And then the next question is, how do you keep that level? Because if that level is so high at 28 days and I top up a high level again, in my understanding, that should go higher and higher. So I'm confused. Can you help me?
Yeah. So the figure that I showed you was actually a couple of monthly doses, and you can see that it doesn't just keep doing that. We saw our people stay pretty consistent, and the main reason for that is that when you give someone who's already got a high vitamin D level a supplement, it doesn't change very much. You hit a plateau, so we keep them fairly stable. In terms of where the vitamin D is stored, we're looking at 25-hydroxy-D, so vitamin D itself gets converted to that intermediate molecule, and it's probably stored in fat. And it has quite a long half-life.
Thank you for describing this totally commendable trial. It was a very, very good summary. I'm just interested in the practicality of how you interpret a tertiary cardiovascular outcome when the confidence intervals are borderline. They actually cross zero. What is the message that we can take away from something like that, and how should we promulgate that as a result?
Yeah, it's a good question that we've grappled with a lot. Obviously, trialists don't like tertiary outcomes. Had we set out to do a study of the effect of vitamin D on cardiovascular disease, it would then have been a primary outcome. And then people would argue that we may interpret it somewhat differently. And so I think it's really important to put it into that context and to recognise that there was a pre-specified outcome, and all our analyses were done very, very much blinded. There was absolutely no data dredging going on. The fact that it crosses, that confidence interval crosses 1, had we used a different confidence interval, it wouldn't have crossed 1. So it's sort of statistics, and, you know, you can interpret it how you will. But that's why we're somewhat cautious in terms of, should we be moving to population-wide recommendations on something like that, or should we not? And we've all grappled with it, as have that study is published in the BMJ. And the reviewers grappled with that exact issue as well in how we interpret it. And I don't have a black and white answer for you, other than we are very reluctant to interpret confidence intervals and p-values as black and white, and we need to consider the evidence in its totality.
Thanks. Fantastic science. Can I invite you to comment perhaps on the implications for funding such a study like this? Obviously, this needed lots of grants in sequence that all fell in a good way. So what do you think the implications of, you know, doing such a big trial over a decade mean for the way we fund clinical trials like this in Australia? Could you comment, or even tell us what contingencies or what you might have had to do along the way to just keep that going?
Yeah, so one of the major contingencies was that the large trial was funded by 2 5-year grants, but actually they weren't consecutive. There was an overlap year between them, because we had to apply a year early, just in case we were unsuccessful, so that we made sure that we had some follow-up time for people who were still on drug, because we posted a year's worth of tablets at a time. And it did actually mean that instead of having 10 years of funding, we had 9 years of funding because of that overlap here in the middle. What I think should happen for these large-scale trials, because it's a huge amount of work, and I think people need to actually be upfront with the NHMRC and say, this is a 10-year study, and you need to be able to say, yes, we will fund that 10-year study. And clearly you need to be proving that you've been successful along the way in order to keep that funding flowing, and it should stop if it's being unsuccessful. But I do think if we're going to do these large-scale studies, whether or not they be trials or otherwise, we absolutely need to be committing to long-term funding of them, because it caused me significant stress.